So with that background in mind, we're going to start this talk today by Dr. Osman Faheem, who's actually the first few started TAVIs in Pakistan and has done a great job in Khan Hospital. So we look forward to hearing from him regarding the procedural aspects of TAVI today. And he's going to stick to the basics and in half an hour, and then we'll have a discussion among the panelists about what they would do differently or in different approach they would take, or any additional messages they have on that. So Usman, the stage is yours. So please shuru kijega.
Thank you, Nouman, so much for giving me the opportunity, and to PSIC leadership and to GETS for coming up with this fantastic program. So let me just share my screen. I hope everyone can see this.
Yes, we can.
All right, so if you have not had a chance to review this document, I would encourage all of you to review it. And it is really a comprehensive document that gives you all the essentials that you need to know for your TAVI program, whether you're a new program or an established program. This is really a very nicely put together thing. And I'm just going to go through a couple of the salient features of it. And begin with quality outcome metrics that this document suggests. Now, all the societies, surgical as well as interventional cardiology and cardiology, have come together to produce this document. And basically, this is the criteria that determines your outcomes. And when you are part of a TAVI program in the US, you're part of the TVT registry, and all the data that's collected is looking at these things. So for your in-hospital outcomes, you're looking at aborted procedures, conversion to open heart surgery, unplanned mechanical circulatory support, necessary second valve or valve-in-valve TAVI during the procedure, cardiac arrest, annular disruption or dissection, device embolization, device implant success or failure, class 3 kidney disease, new pacemaker. So that's all in-hospital. And for your 30-day all-cause rehospitalization day rate is part of your 30-day outcome. And at that point, there is a Kansas City questionnaire, and your score on that is also documented as an outcome and how well the patients are doing on that. And that was part of the bane of our existence doing this in the US, because the nurse practitioner used to have to spend a lot of time with the patient at their 30-day follow-up, trying to figure out what improvement in quality of life they had. And then at 1 year, all-cause mortality, as well as the Kansas City questionnaire. This document suggests that you need about 50 cases per year or 100 cases over 2 years to ideally achieve proficiency. Obviously, those numbers are from the West, and in our context and landscape, it may not be directly applicable. But these outcomes are applicable, and so when you are doing your cases, that's what you have to remember. As Nouman mentioned, it takes a village to do these, and this is what you need. But quite essentially, you need people that can help you if there's things that go bad. So you need electrophysiology and neurology, you need your nephrologist to be around. The knowledge base and skills that's required, again, there's a lot of stuff that you need to know, but basically you need to understand the anatomy of the aortic annulus really well. And Asaad had talked about that previously, but the distribution of calcium in the aortic valve annulus, the LV outflow tract and the aorta, the sinuses of Valsalva, whether or not there's hypertrophy of the basal septum, location of the coronary arteries, calcification, dilatation, and angulation and tortuosity of the aorta, and calcification, tortuosity, and caliber of the iliofemoral and brachiocephalic vessels, because those will be your access points. So these are things that as you head into your procedure, you need to be comfortable with, aware of, and review for each patient. So, again, this is a brief overview, but comfort with large bore access, balloon valvuloplasty, comfort with advanced wire skills and knowledge of guide wire technologies, different kinds of stiff wires, short and long wires, and which wire to use in what circumstance, access to retrieval devices. So when you get into the actual procedure, you need to make sure your lab is stocked with all of this equipment as well, because you don't want to be halfway down a procedure or have a valve issue and then realize that you don't have retrieval devices in the cath lab. You need to be comfortable with peripheral vascular diagnostics and interventional techniques and usage of covered stents, whether they're self-expanding or balloon expandable, and have some of those stents available in certain sizes. In our lab, anywhere from 5 to 8 millimeter balloon expandable stent, covered stents are always available, so that in case there's any kind of vascular catastrophe, we have those to help bail us out. The surgeons need to be comfortable with abdominal and thoracic aortic repair, whether that's endovascular or open. We don't have percutaneous mechanical support devices, but the balloon pump is always there in the room when we do the procedure. Some degree of comfort with knowledge of percutaneous closure or paravalvular leaks, whether that's required acutely during the case or patients come back with a PVL. That ability is helpful. And then your EP colleagues to help treat rhythm disturbances, or somebody who would be able to put in a pacemaker, and an understanding of indication of pacemakers in the TAVR setting. So when you're doing the procedure, it's either in the cath lab or a hybrid OR. I think most cases can be done in the cath lab pretty comfortably. You need to have good imaging, as Dr. Nouman mentioned, and somebody who's a non-invasive person who is interested in transthoracic echo and TE, as well as 3D echo, and can help you out with that. A vascular lab, not just for pre-op workup in terms of looking at carotids, but in case there's a vascular problem post-procedure, like femoral artery stenosis or dissection or something, then vascular imaging is important. And then a dedicated CT lab. When you get into your procedure, you need to decide what your bailout is. I know previously we had a conversation and it was mentioned that cardiopulmonary bypass is, some people had surgeons in the room. We have surgeons in the room for deployment of the valve, and we have cardiopulmonary bypass equipment in the room. Not every program does that. Everyone has their different thing, but you need to know what your bailout strategy is in case a patient goes bad and you need to put them either on pump or they need to go to the OR. What will be your plan, and practice that plan a few times. I think there was one time when somewhere in the US, they were trying to move a patient, and they found out that with all the equipment that the patient was on, they couldn't fit into the elevator and couldn't make it to the OR because of that. So, simple things that are small things become big things when you have a sick patient who's crashing. So have a plan for that one patient who may go bad. You may never need to use it. The technology is great. The risk of complications with TAVR is getting lower and lower each day, but you should have a plan. And so we already kind of went through this, but kind of the equipment that you need to maintain. So wide range of sheets, both coronary guide wires as well as 035 wires and extra support wires, an array of diagnostic and interventional catheters, vascular closure devices. As far as I'm aware, only ProGlides are available. I don't think we have angioseals or any other devices. Some other institutions may have them. We just have ProGlide on the shelf. And then balloon dilation catheters of various lengths, stents, as well as coronary and peripheral covered stents. Large balloons that can occlude the iliofemoral system are also helpful. You should have snares. And then devices such as AVP2 or PDA closure devices, or some other device that can be used for PVL leakage, that should be there. your plan for anesthesia, whether that's going to be general, which is usually not a lot of cases anymore, or MAC and conscious sedation, which is the large amount of cases. Largely, general anesthesia is now reserved for alternative access or transaxillary, and even that can be done on conscious sedation, but transcarotid or direct aortic and transapical hardly ever being done anymore. But general anesthesia are definitely required for those, mostly MAC and conscious sedation required for transfemoral access. We use a cardiac anesthesiologist. Good to have them on board. They keep the patients very stable, but general anesthesiologist might work as well. Typically, we don't put in Foley catheters. We don't put in any central lines, just our femoral, venous, and arterial access. The side arms we give off to the anesthesiologist, and they maintain access through that. So at the end of the case, when the patient is done and is being moved, everything comes out. There are no central lines left in the patient, and that helps with their recovery and getting an early mobilization. Access is generally transfemoral thanks to lower profile sheets. About 85 to 90% of global cases are now done transfemorally. Alternative access options are transcarotid, transaxillary. Direct aortic transapical is less so now, and transcaval for really like is extreme non-femoral access option cases. You need to think about your room setup. So you'd have two operators. Transfemoral is pretty easy. It's very similar to a cath setup. You're on the right side of the patient, equipment behind you, anesthesiologist at the head of the table, transthoracic echo machine. We just have the machine in the room. We don't have the echocardiographers in the room anymore. And then there's another table off to the side for valve preparation. And this is pretty much identical to what we have. You have your nice big screen up here, so for easy visualization. If you're doing an alternative access, then the room setup might be different. The operators may need to be at the head of the table with an accessory table, because if you're accessing transcarotid or axillary, whether that's right axillary or left axillary, your catheter is long and it's going to come back. And so you need to have a smaller table right behind where the catheter is coming off the table, and then a longer table, whether that's along the patient or along behind where you are. But as the first operator, you would probably be standing there, somebody else holding the sheath here, and another third person here. Anesthesia and echo and everybody gets pulled off to the side, and your screens would be at the foot of the table so that when you're standing at the head, you can look directly across the patient and the case. So think about the room setup depending on the case and the access. So when you the case, basically, you can divide into 5 parts. It's the access, you cross the valve, you do a balloon valvuloplasty, or you may not these days. You do the valve implantation and then access closure. And that's what I'm going to go over in the next step. So we always begin with the team huddle. All patient information is reviewed. So we're there, the cardiac anesthesiologist is there, and somebody from the cardiac surgery team, usually one of the residents, is there. And there's a plan that in case something goes bad, are they going to go on pump femorally or they're going to open up the chest? Hasn't happened so far, but there's always a plan for every patient. And some patients who are very sick and inoperable, we already talked to the patient and they're not surgical candidates, so we don't have any plan for if they crash and go south. You review your sedation plan, whether it's going to be MAC or general anesthesia. At that point, you would review your echo and cath findings. This is important. You want to review your coronary anatomy, make sure there's if there's disease, because a lot of these patients are maybe unrevascularized. They may have diffuse 3-vessel disease, some of these older patients. Or they may have completely normal coronaries. You want to refresh that, because I know I see patients, sometimes 3 or 4 weeks before, and you don't really remember all of their details. So this is a good time to review all the essentials. The echo is important because you want to see what the EF is. If they have concomitant valvular disease, that can play a role. Pulmonary hypertension usually can get troublesome. Severe mitral stenosis would be troublesome when you rapid pace the patient. So this is where you refresh all of those essential details so that they're in your mind as you're making decisions during the case. And then you review your TAVI CT findings. You look at the annulus size, make sure you've determined the right valve size, the coronary heights, calcification, access plan, and implant angles. You also review the risk of a pacemaker. Some people have completely normal ECGs and their risk of pacemaker with the valve going in may not be elevated, but some of them may have pre-existing conduction abnormalities, and that may play into your decision of how diligent you're going to be about the depth of valve implantation, and I'll talk about that a little bit later on. Sometimes it's a trade-off between how deep the valve is going to be, how much PVL you're going to get, and what the risk of requiring a pacemaker is. So this is the time to review that as well. If you're planning on doing a balloon aortic valvuloplasty, you make sure you have the right size, and then discuss the bailout strategy if anything goes south. Asaad talked about this. I'm going to briefly touch on this. These are the details that you need to be comfortable with measuring yourself, as well as reviewing on the report that you get from your industry colleagues, depending on which valve you're using. But the annulus perimeter or area, the coronary heights, both the left and right, the sinus depth, the STJ junction. This is important during the procedure, especially if you're doing a balloon valvuloplasty. You don't want to use a balloon that's too big that may cause a disruption either at the STJ or at the annulus. So these measurements need to be revised, and then the ascending aorta. Also review your femoral access size, tortuosity, whether there's any, sometimes there's aortic tortuosity, and right at the diaphragm there's a bend, so you want to review that and not have any surprises during the case. So when you get down to, if you could kindly mute your laptop or phone, please. So when you get down to access, we use both ultrasound as well as femoral access to, as well as fluoro imaging to get femoral access. We used to use micropuncture in the US, but here we don't have micropuncture. We just use the regular Cook needle and with a modified Seldinger technique. We put in a 4 French sheath dilator and take a picture and make sure we're not in the bifurcation. This also, when you review your CT scan pre-procedure, you should look at where the bifurcation is and in relation to the femoral head, and that'll help you decide whether you're going right femoral or left femoral and where you're going to stick. Once you have that access, we put in a 6 French sheath, and over that sheath we do our per-close technique. So you should all be familiar with doing per-close. I'm not going to go through all the steps, but basically it's a device that goes in and has a needle with suture mechanism that you deploy. The needle passes the suture through the wall of the artery. You externalize the sutures and are able to take them out and put them off to the side for the duration of the case. And once the case is done, then you can close it. Most valves these days, whether that's Edwards or Medtronic, the minimum vessel requirement is 5 millimeter. It can actually be smaller if there's no calcium. We've done vessels as small as almost just below 4 millimeters, or they can be 6 millimeters or 7 millimeters with a ton of calcium and tortuosity, and that becomes a problem as well. So vessel size is one of them. Tortuosity and femoral and calcification is the other one. Use your fluoro and ultrasound to help you get the right access, because if the access is troublesome, it's going to bother you throughout the case. A lot of programs use crossover wire technique. That just means you access the contralateral groin and you put in an 018 wire down the femoral that's going to have the larger sheath. We don't do that. I've never had to do that. Programs still do it, and you can do it. It gives you some degree of comfort that if there's a problem, you can balloon occlude the vessel if there's a perforation or a dissection. Temporary pacing, you have 2 options. You can either put in through your venous access, you can put in a DVP in the right ventricle. You will require rapid pacing during balloon valvuloplasty, some degree of pacing during the implantation of the valve prosthesis. And if you're going to do post dilation, or if there's conduction disturbances, you'll need the pacemaker. Alternatively, you could use the LV wire for pacing, and I think Ali Raza has talked about that really very eloquently. Basically, you put an alligator clip on the back of your LV wire, and then you put the other electrode through a needle in the patient's skin, and you just use the wire to pace directly in the LV. Works quite well, and it saves you some time. Predictors of requiring a permanent pacemaker, so it's diabetics, right bundle branch block, baseline AV block, left anterior fascicular block, high degree of calcium in the left cusp or the non-coronary cusp. Self-expanding valves, as we all know, higher incidence of pacemaker than balloon expandable valves. The depth of the implant matters as well. Valve size and annulus size, and how much you're oversizing your valve in relation to the patient's annulus matters. Generally, more than 30% for self-expanding and more than 20% for balloon expanding valves. If you're oversizing in relation to the patient's annulus, you run a risk of a pacemaker. If you're doing a pre-dilation or post-dilation balloon valvuloplasty, that also increases the chances of requiring a pacemaker. So once you have your access, you've got your ProGlides in, you've upsized to your large sheath, or you've upsized to an 8 French sheath, you are getting ready to cross the aortic valve. We usually cross the aortic valve with the help of a JR4 and AL1. It gives you a nice angle, and we use a soft tip straight wire. It's non-hydrophilic coated, works well in most cases. Sometimes if it's a bicuspid valve, you may need to use a hydrophilic coated wire like a glide wire to access it, but otherwise this wire works perfectly fine. Once you cross the aortic valve, then you exchange this for a stiffer wire. And the way the wire moves in the ventricle, and this comes with, as you do more and more cases, should give you a sense for whether you're entangled in the subvalvular mitral apparatus or not. You want to make sure you're free of the mitral valve apparatus, especially if you're doing a BAV. Originally, we used to use Amplats extra and super stiff wires that were straight wires that we used to put a bend on it. Now we use dedicated pre-shaped wires, Confida mostly, and Safari occasionally. You want to have access to Lunderquist or very stiff wires, because if there's a lot of aortic tortuosity or a very horizontal route, that can help you position the valve better. So basically, this is an AL1 catheter. Your pigtail is in your non-coronary cusp, and you use this straight wire to cross. Once the wire is across, you push in the AL1 into the left ventricle, and then either through the AL1 or you switch out the AL1 with a 300 centimeter J wire, put in a pigtail, and then put in your stiff wire through that pigtail. You get a nice loop in the ventricle, and you're ready to proceed to the next step of your procedure. The implant angle matters a lot. So, there are two views in which you can work. There's the 3-cusp view, as well as the cusp overlap view. And so the 3-cusp view is basically the view that your CT scan will give you an approximate angle, which shows you all 3 cusps lined up as the right, and the left cusp. In the cusp overlap view, you'll have the non-isolated. So you go to your 3-cusp view and then rotate your II to get to a point. And usually that's a little bit caudal and maybe a little bit RAO or LAO, where you would isolate the non-coronary cusp, which is the lowest cusp, and you would overlap the left and the right cusp. This has become, the cusp overlap view has become the default angle of implant for most people. It shows you, because the left cusp is the lowest, as long as you're at or below the left cusp, you should be below the right because the non-cusp is the lowest, and if you're at the level of the non-cusp or below it, you should be below the right as well as the left cusp. And so this is an important concept to understand. So you really want to make sure that you get your cusp overlap view and are comfortable with implanting your valve in this view. This has also been shown to reduce chances of requiring a pacemaker, because your depth becomes, you can manage the depth of your valve quite well. In the 3-cusp overlap view, because there is a lot of chance for parallax error, you tend to implant deeper. And if you look at this, the AV node is right below the non-cusp. And so if you're deep, you're going to compress the AV node, and there's chances of a high-grade AV block. So in the cusp overlap view, you move, you move your non-cusp kind of away from the AV node. And second, if you're not that deep, you'll have less chances of pacemaker rates. And this has been shown in the aligned TAVR study, that the cusp overlap view does reduce your pacer rates as well. So once you have your view sorted out, and if you're deciding to do a BAV, the required sheet size is anywhere from 8 to 12 French. That is the depends on what balloon you're using. These balloons are typically 3 and 6 centimeter in length. Try to use a 4 centimeter balloon. It makes life easier. It's less likely to embolize into the LV or into the aorta. We use a 90-10, 90 cc saline, 10 cc, 90% saline, 10% contrast for radiopacity of the balloon and to prep the balloon, and allows for rapid deflation as well. The balloon may require anywhere up to 60 ml in there to inflate it, so we use a 60 cc syringe. The semi-compliant balloons are like TISHAG. Those tend to rupture easily but are less traumatic. The non-compliant balloons like ZMed, Maxi balloons are stiffer, but they don't rupture. And so these days, because of availability, whatever balloon you can lay your hands on, pretty much we just end up using that. So for balloon valvuloplasty, you already have your TVP in, or you have your pacing through your left LV wire. You've got your LV wire across the valve and into the LV apex. The balloon, I don't know if it's projecting well, but the balloon has two markers, one proximal and the other distal. Your valve should be roughly in the middle of those two markers. You rapid pace typically at a rate of about 160 to 180 beats per minute, get their systolic blood pressure down to 60, and then quickly go up on the balloon. You will see a waste depending on how much calcium and how severely narrow the valve is. The waste mostly should go away. You should be up for about 3 seconds, and then you deflate and stop pacing and pull the balloon back into the aorta. The important thing is a stiff wire. You should have your stiff wire in there. Don't do this over a usual 300 centimeter J-tip wire. This is over an Amplatz Extra or Super Stiff, or your Safari or Confida wires. Typically, the indication for BAV these days is heavy calcium, mean grain greater than 50, or peak velocity greater than 5, or bicuspids. We tend to balloon all of them. All of our bicuspids for valve positioning makes life easier. The other thing is sometimes you're worried about coronary flow. If there's a low coronary and risk of obstruction, you can do a balloon inflation while the balloon is up, do a pigtail injection, and you can see if there's coronary flow or not. The way the balloon is sized is you use one size smaller than the mean diameter that you get off of your CT scan. That's what we tend to use for your pre-BAV. Just quickly to understand the valve design. Sorry, this is not a good quality image, but since most of us are doing the self-expanding valves, this is the numbers that you need to know. So what you will see on the valve as when it's handed to you are these nodes, and there's the first marker. So between the first marker and the first node, the nodes are these dark lines, is 6 millimeters. And from this marker onwards is 4 millimeters for each. And these correspond to these points of contact in the wire mesh. That's the supporting structure for the bioprosthetic valve. And this is what helps you figure out what your valve depth is. And this is important to understand. Your ideal depth is about 3 millimeters, and definitely no more than 5 millimeters. So when you're doing your implant, you're looking at this at the first marker and the second marker, and that's going to help you figure out where you are in relation to your aortic annulus and how deep you're going to end up. The other things to understand are that the skirt goes up to about 13 millimeters all the way around. The commissures go up much higher. I believe they go up to 26 millimeters, and these gaps between the wire mesh are about 16 French. If you need to get in through the, sorry, not 16, I think 10 French or 12 French. But you should have an understanding. These measurements are available online to look at, but ideally you need to understand the nodes and the distance. The first two nodes are 6 millimeters apart, then each one after that is 4 millimeters apart, and that helps you decide your implant depth. Basic understanding of the catheter. This is what it looks like. So there's a capsule that encloses the valve. There's a nose cone that helps you get into the skin. The inline sheath is pushed up all the way to this capsule. So this whole thing, the nose cone, the valve with its enclosing sheath, and the inline sheath all acts as one unit that goes in as a 14 French inline system. There's a flush port for your inline sheath. There's a small port over here that's important that you need to know about, the handle right here, which is what you turn counterclockwise to gradually deploy the valve. And then there's the exit port and another flush port at the back. When the valve is handed off to you, you're going to inspect it under cine, 30 frame cine, and look at the paddles. The paddles should be symmetrical. The valve should be straight. There should be no dissymmetry or asymmetry in the valve. If the paddles are off in any way, so for instance, in this, the paddles are not quite symmetric. Here you can see the paddles are equal and are right where they need to be. Here, one paddle is very close to the hook, and the other one there's a distance. This is not right. So you need to reload this valve. So take your time looking at these valves, make sure it's been prepped appropriately, and there is no asymmetry anywhere. It should all be very equal and symmetrical. Commissural alignment is also another concept that's come up, and it's important. So the idea is the bioprosthetic valve has its own commissures. And so you want to try to avoid lining those up in front of the left main, because in the future, if the patient needs access to the coronaries, if this portion of the valve is right in front of the left main, as you can see, the skirt goes all the way up until here as a point of attachment for the leaflets. You will not be able to access, sorry. This is it. So sorry about that. So you need to make sure that this commissure does not end up in front of the left main. And so this port on the handle of the delivery catheter, it goes, when you're going in, should be at 3 o'clock. So it should be facing away from your second operator at the 3 o'clock position. And that allows you to make sure that that commissure does not end up in front of the left main. And as you're going in, this what they call the hat or the L-shaped thing is this L-shaped thing should be on the outer curvature as you're going in. It should not be on the inner curvature. So you can see that this L-shaped metal structure is on the outer curvature. If it's on the inner curvature, then your commissure might be in front of the left main, and you need to realign it. So this port at 3 o'clock and this L-shaped structure on the outer curvature will minimize the chances of that commissure ending up in front of the left main and will allow future access to the coronaries. So it's more of that same. So when you're in, your pigtail is right in the non-coronary cusp, right at the bottom of it. Your starting position and this L-shaped structure is going to be in the middle of that pigtail, and that's going to be a starting point. The valves tend to dive down as you deploy them, especially if it's a 29 or 34 millimeter valve. It is going to dive into the LV outflow tract. And so starting up higher is going to help make sure that you don't end up too deep. You've got your pacing wire there, and some people don't pace. I generally tend to pace at a slow speed of about 100 or 110. And some people still rapid pace for Medtronic deployment. It all depends on how comfortable you are, how stable the valve is. Sometimes the valve moves a lot, and rapid pacing does tend to help. This is a figure showing where you want to end up. So remember, from the first node to the second node is 6 millimeters, and then from there onwards, it's 4 millimeters. And so you are going to try to be somewhere at the 3 to 5 millimeter mark in terms of your depth. So this is your non-coronary cusp, and then overlap right and left coronary cusps. And that's your goal, to end up about this deep, which is going to minimize your chances of a pacemaker. And that's a good implant depth. Visually, it's about 1/4 of that first diamond is how deep you want to be. So ideally, no more than 1/4 of that diamond should be below the annular plane. You will take an injection once you've had 2/3 deployment. So at this position, you start, if you're pacing, you start pacing, you gradually go counterclockwise on your delivery catheter and start unsheathing the valve. The valve will gradually open up and make contact. And then as you deploy it more, your blood pressure will fall. That's the point where you want to unsheath it more rapidly and then get to the 2/3 deployment, at which point the valve is mostly functional and your blood pressure should come up. This is the time when you pause and you reassess the valve. The catheter has this inbuilt mechanism. You get this loud grating noise when you reach 2/3. So when you get to that point, you slow down and pressure comes up, then you stop. So this is your cusp overlap view. You take through your pigtail, you take a root shot and see what your depth is. Looks a little bit deep over here, actually. And then you go LAO and you go to your 3 cusp view and take another shot. And you can see this is the same valve. It looks a little less expanded in this view, looks more expanded in this view. But these 2 views, you assess the valve in, you see how stable it is. You give it a few minutes, see if the valve's moving or not. Sometimes the valve will tend to move gradually towards the aorta because it might not be stable and you may need to reposition it. This is also the time when you take your injection, you look at the coronaries and make sure you have coronary flow. So your immediate post-implant assessment is going to be aortic regurgitation. So how much PVL there is. Sometimes there is a lot of aortic regurgitation. It's hard to tell if it's PVL or it's because you still have equipment across the valve. That's where transthoracic echo, if your windows are good in the apical views, may help you get some sense of whether it's PVL or all through the aorta because you have equipment. We all know that moderate to severe AI is associated with worse outcomes and could be due to incorrect valve sizing, suboptimal positioning, calcification, or incomplete valve expansion. So you're going to assess with aortography, echo, as well as invasive hemodynamics. Sometimes it looks bad on your root shot, but there's a huge gap between your diastolic aortic pressure and your LVEDP, and so you know that that's not significant AI. You can either recapture and reposition or post-dilate the valve depending on the mechanism. And typically you don't want to oversize greater than 30% for self-expanding valves. But you do want to oversize generally about at least 20%. This I already talked about. For the other immediate thing that you assess is your conduction abnormalities. And so low implant depth is going to help. If there's any conduction abnormality, so if the patient develops second-degree AV block or complete heart block, even transiently, then you might want to keep your TAVP in. If that happens, you need to have EP on standby and beta blocker and calcium channel blocker on there. So then if everything looks good, you start wrapping up. You remove the large sheath over a J-tipped guide wire. You deploy your ProGlide. Make sure you have good hemostasis. You check your distal pulses. Typically, if the pulses are good, we give protamine. And if there is an issue with the pulses or we're not sure about the flow, then we'll just take a quick shot or angio of the femoral area and make sure that there is no issue and then give protamine. But unless the patients also had a PCI during the same procedure, we do give protamine to all our patients. Post-procedure, the patient goes to the CCU for observation, groin checks, and vascular checks, rhythm monitoring, hemodynamic parameters. If they're on any inotropic support, that gets weaned off their neuro assessment. We give antibiotic prophylaxis, cefazolin pre-procedure, and 2 more doses of cefazolin post-procedure. Antiplatelet therapy, some people just start off 75 milligrams of Plavix, some load. I tend to load and then just transition to 75 of Plavix, and then resumption of home meds and activity, getting them out of bed and stuff. So I think this I already reviewed, so I will skip over this. So kind of pearls and pitfalls, especially for Evolute platform, if your diameter and your CT measurements are between 2 valve sizes, consider the larger valve size. If your coronary height and sinus of Valsalva permits, that's the nice thing about the self-expanding valves, that your risk of annular disruption is really quite low, so you can oversize and get a nice result. Obviously, your pacemaker risk does go up. Don't try to minimize your amount of contrast. We follow that as an outcome for our patients, how much contrast is for each procedure. When you do your perclose, make sure you do some subcutaneous dissection so that your knot gets right down to the arteriotomy. Sometimes it can, especially in obese patients, can get stuck in the soft tissue and you don't get good hemostasis. Be careful with your TVP in the right ventricle. It's been known to puncture through, especially the ones we don't have balloon expanding ones for some reason, so balloon tipped ones. So be very careful with the TVP and use your LV wire if you're comfortable doing that. For pacing, and always be mindful of the position of your stiff wire. The worst thing is you do a lot of hard work, cross, and then the wire comes back and you have to start all over again. So with that, I think I'm done, and I'll open
you, Great talk, superb talk, covered everything very nicely. You're going a little bit over time, but I didn't want to interrupt because I wanted everything covered, and that was really nicely done. So now I think we'll open the floor to question answers and comments and discussion by the panelists. So Tahir, Saghir, are you there? Can you hear me?
Yes, I can hear you.
Okay, Tahir. So your thoughts of, in terms of at NICVD, are you doing any things differently? Actually, I had a question from you from last time you mentioned that you were getting closing the arteriotomy site with a single ProGlide. Yeah. So can you share your experience with that? I've not seen that done. I mean, we always use two ProGlides at 2 o'clock and 10 o'clock position. So
one thing which we have started for the last almost 3 or 4 months, we have the availability of the micropuncture. And that makes our life very much easy, especially the access site for the procedure where at some time we have a higher bifurcation and a lower inferior epigastric artery. So with the help of IVUS ultrasound guided micropuncture, we have a very precise and adequate site to puncture. And that's helped us a lot. Number one thing, and it's available, but due to cost, people are not using. And for the last, I think 3-4 months, we are using a single ProGlide, and it works well. So far, in one case where the ProGlide didn't function, the first one, we have to put another one. Otherwise, we use a single ProGlide.
And after that, you don't have issues with the hemostasis?
No.
Pressure for, how long do you hold pressure? It's just...
just we give the protamine after the procedure and just hold for a pressure almost 5 to 10 minutes.
That's great, because that's the first I've heard. I mean, I've seen people use ProGlide and an angioseal combination, but you're just using a single ProGlide. So micropuncture kit is available. I mean, in US, we use micropuncture. Over here, we have to go with the 4 French sheets. So good to know. We'll try to get hold of that as well.
We have been doing the same. We have the micropuncture also, and if everything is okay, using a single. We have angioseal as a backup also. If needed, we can use it.
Where did you get the angioseals from?
I got it from US on my own. So
okay.
Yeah. But I think it's a
and if the one ProGlide fails, or if there's bleeding, if you keep your wire in, you can just put in a 6 French sheath usually, and then you just have a patient with a 6
I think that could.
So that's what we have been doing, the angioseal, in case if we need to put the sheath and get the angioseal in.
All right.
Great talk, Faheem. I think it was great. And one I think which I would we have stressed in the previous talks also, and this one, the most important thing I think we need to learn is the pre-procedure evaluation. We have to be very, very meticulous about the patient, clinical history, physical examination, all the workup, echo, CT. You need to review it yourself and look at all the parameters and make sure. I think the success all depends on your pre-procedure evaluation. Our fellows and everyone is like concentrated most of the time on the procedure itself, and I keep telling them even during interventions or CATs also that pre and post is also very important. But I think in TAVI it can't be stressed more than please focus on the pre-procedure evaluation, and also obviously you have to keep an eye post-procedure. Procedure itself is not a big deal if you are able to really make sure that everything is appropriate and on CT and echo and clinical history and all those things.
Well, thank you for your valuable comments. Asaad, your thoughts?
I think, first of all, amazing talk, Osman, and I don't think there's much to add. Couple of things. I think the first point I wrote is what Bashir Saab already said, that I think in Pakistan especially, this baseline frailty level of the patient needs to be assessed by multiple people before you actually agree to doing a procedure, because they expect, if they're spending 3-4 million on a patient, they would expect everything to be fixed with it. So I think counseling as well as assessment of the patient is pretty critical. Secondly, I think he covered everything. Couple of additional things which I feel maybe depends on fine-tuning of the technique regarding that cusp overlap technique that we discussed. Himal Gada, who is probably the main proponent of cusp overlap and who introduced it to the wider audience in US, he actually advocates for use of Lundquist as a routine wire for all cusp overlap procedures. And I think we have used it a couple of times in our couple of cases that we did recently, and it actually aligns the valve much more comfortably along the outer curvature. And then just in terms of the balloons that we were mentioning, I know Taishak is a very compliant balloon, but these Z-meds that we get are also pretty semi-compliant. And I think the ideal balloons that we use in US are the true balloons, which are the proper non-compliant balloons for post-dilatation at least. And then lastly, I think Osman was mentioning everything in detail, and probably he showed it in an image, but I think the point that was skipped through was that the wire has always needs to be centered during the deployment. So if it's along the outer curvature, you always pull it back a bit. If it's along the inner curvature, you push it back, push it in a bit. So just these few things, but I think he covered everything. These are just like probably points that I'm trying to add in there. But even without these, the talk was fantastic.
Can I ask you, sorry, Nouman, sorry, just a quick question from the panelists and Osman also. Like, what is the cutoff age we are using in Pakistan? I was kind of surprised. I was like last month in US working there, and I sent a patient for Saghir. He was like 53 or 54 years old. And 2 days after, the surgeons called me back and he said that they decided to go ahead with Tabba instead of Saghir. So what kind of age cutoff we are using?
So I think we had a question on this in the first one about the age thing. I guess the panelists can comment as to what they're using, but 50 to 65 is generally Saghir recommended, but a lot of you see in US all the time, people in the 50s opting for the biphasic valve, going for a Tabba, and it's happening a lot. And nobody can, so in Pakistan, I guess we discussed that life expectancy is less, maybe the cutoffs would be 10 years less. So open to panelists on comments on the age part.
So I think the issue is going to become less about the age and more about lifetime valve management. I think that's the key now. And that's where your pre-procedure planning that Dr. Bashir mentioned, that you need to really understand that when this valve fails, what's your next plan going to be? And so in the US, because they're doing multi sapien and you don't have issues with coronary access further downstream, if you're going to put in a 26 or 29 millimeter valve, the coronaries are high enough, sinus depth is great, they can get a second TAVI or a third TAVI. And that's why those patients, even if they're young, below the age of 6, initial procedure, because the options for a couple more TAVIs down the road will be.
I think that is very important for a valve in valve, going with the balloon expandable first to prevent problems in future will be a thing. And then there is this debate always that if you have to go for a surgical thing after a TAVI, does it increase your mortality or surgical complications? I guess the data is not too much data on that either. There was a question you mentioned about cusp overlap, Asaad, and I guess all of us are doing on not on Lundquist, but on Confida or other wires, and the technique works fine on the other wires as well. But if you have a Lundquist wire, it works much better in terms of alignment. Do you guys have the Lundquist wire? I mean, we haven't had access to that over here.
So we had a few. We have used all of them now, so we don't have any more. So we did a valve in valve with a very horizontal aorta with it as well. So it works like, again, you don't have to use it in every case, I think, but what I was trying to mention was that the person who has actually introduced the technique, he feels that that's the only wire that you should be doing all these procedures on.
Yeah,
so we have tried it in a couple of cases.
So Dr. Ali Raza is with us as well. Your thoughts, Ali? He's really helped us with the program over in Bahria. And so your thoughts, please share your thoughts regarding the procedural aspects in terms of what you want to add. And then we have a few questions. We'll try to answer them.
Sure. First of all, Osman, thank you so much for a very good presentation. I learned a few tips from it as well. I think it as Osman mentioned as well, it differs from operators to operators and where they have been trained a little bit. I think the overall procedure aspect remains the same, as Bashir Saab mentioned as well, that you have to pre-plan it, and it all depends on the pre-planning of your procedure, and you can add or reduce few of the steps which you have to do from it. I think, yes, availability of the things. We mentioned that sometimes you have to change your procedure according to the availability of the stuff which you have as well. Single pro glides is being used as well, but I don't know. I wanted to ask as well from Tahir Saab and Bashir Saab, do you guys leave the wire in and then apply pressure and after that assess and then do it, or what do you guys do? Because you will need a wire access for anything else which you have to put in. So do you usually do that with it?
Initially, for the first 5 or 6 minutes, when we give the protamine, after 5 to 6 minutes, we usually pull the wire out.
So yeah, so I think and what's the experience with the?
To make sure, then we
Sorry,
pull it out. Initially, we do leave the wire in, and then later on just pull it out in a few minutes, as I mentioned, if everything's okay.
Yeah, I use it for the coarctation patients. Probably we use it because they've got a different kind of flow and things. But yes, I think it will be money saving as well for Pakistan, because you have to save money on the program.
So we have a few questions as well.
Nouman, can I have a comment?
Sure.
Actually, Osman has covered all the things. I just like to have a comment regarding our audience. When we are done with the procedure, we pull the wire in the LV, the floppy part to the nose cone. That aligns the nose cone in the center of the valve. And then we pull the valve out. Otherwise, if we go with the harder end of the wire and we pull the nose cone, at times it is stuck in the valve and pull the valve up. So it just take care of this minimal, this technique or procedure at the end of the.
Yeah, very crucial point that when you are, and it has happened in a live conference, you've seen some, that you're done with the valve, you're all excited and just pulling the valve back. You have to be very careful that you align the nose cone and pull it back. And then now when you're releasing the valves, I've seen some people pace and sometimes you don't pace. Anybody paces during the time of releasing the valve at the last step?
We routinely,
yeah.
We routinely
120.
Yeah. Regarding the age in our center, actually, although we are doing for free, but the things remain that we are not doing with the balloon expandable. So we have in back of mind, if we go with a evolute and a younger patient, maybe 55, 60, what will we do after 7, 8 or 10 years? So for that matter, for the time being, we usually take more than 65, mostly 70 and 80 years of age.
I think that seems to be a reasonable strategy, especially in the German setup. I think we need to rationalize a little bit as well. So if somebody's self-pay, that's a different thing, but that seems to be a reasonable strategy. Now we have a few questions. In a patient with baseline RBB, is it advisable to put in a prophylactic pacemaker? We haven't done that as a practice, haven't observed that, but any comments? Baseline right bundle, would you advise to put a prophylactic pacemaker? Not recommended routinely. And I guess panelists, yes, no.
I think you can do a Holter if there is a history of syncope and stuff like that, and a Holter shows pauses, maybe, but as a routine, we never do that, especially with now everybody adopting to cusp overlap technique. I think the chances of pacemaker going lower and lower, so probably not as a routine for sure.
So there was a question about trans-cable access, so not done over here. I don't know if anybody's done it over here, but but you have to have a wire to burn through the cava into the aorta. And the thought is because of the negative pressure, it doesn't bleed over there. So you don't need to close that area. You need to just close the venous access site. Correct me if I'm wrong with the panelists. Want to add anything over there?
So we did a couple in the US. So you do need to, you put in an ASD closure device on your way out.
Okay.
So the point of approximation between the aorta and the IVC, because a 14 French sheath goes through it, you put in ASD closure, or sometimes even a PDA closure device can work from the aortic side. And so you leave that, and then yes, it's just a venous access, which is the nice thing about it, that you don't have to worry about arterial access closure. It's just the venous. You can do a figure of 8 suture and just pull everything out at the end. But that's a whole separate talk in itself about where to go transcaval, how much calcium there is, what the difference is between the distances between the IVC and the aorta.
Aorta anatomy in terms of where you're going to puncture and
where the renals are. So it's really like a last ditch kind of effort. And I think between transaxillary and transcarotid, the need for it has also gone down a lot. It's not as necessary as it was becoming at one point.
So there's a question actually, is in 50-60 age group, the gray zone in guidelines, and both can be offered. So guidelines are 50 to 65 prefer SAVR, 65 to 80 is TAVR or SAVR, above 80 is TAVR, what the guidelines are. But again, the US guidelines, you have to individualize what is the life expectancy of that individual patient, and what factors favor SAVR or TAVR. Other questions?
Yeah, I just wanted to add, because Bashir sir raised this as well. And I've always talked about this age, that life expectancy is different in US and different in UK. And so that's why it's 65 in US, 70 in UK. And then Pakistan's life expectancy is 67. So I think we should be a bit flexible in this. If the surgeons are not going to do anything, then I think we should provide them some kind of
I think just using the general life expectancy number is not fair. You have to individualize it, because our life is low because of the MMR, maternal mortality rate, all the other indicators as well. But for a particular individual sitting in front of you, it might be different. So yes, that thing needs to be kept in mind as a overall life expectancy, but individual assessment, again, it comes down to the whole pre-procedure planning and individual assessment. Now, there's a question regarding what are the difficulties, especially with small aortic annulus. Thoughts from the panelists?
I think small aortic annulus along with small sinuses is an issue for core valves. I think for sapien, probably you get away with it as long as your heights are okay. But if you have E-phase sinuses and a small annulus, sometimes you have to turn down the surgery. And it happens in a lot of these smaller size old women who come to our clinics. And I've seen a few of them in Pakistan. I never saw them that frequently in US.
I think he was also probably referring to prosthetic size mismatch issue with the small annulus. So any thoughts on that? I mean, there is a SMART trial going on. I know Javier, one of my mentors from Penn, has started that. And Edwards took quite a,
offense.
Problems with that offense. They've taken away all the.
So my core valve is going to come out better. So yeah, exactly.
But in terms of any thoughts on that, in terms of would you prefer a balloon expandable versus a self-expanding with small annulus? Any thoughts from the panelists?
Yeah, I would go for
So they are moving. So if it's going to be a 23 millimeter sapien, 20 or 23 millimeter sapien, they get left with a significant gradient now with sapien ultra and even sapien 3. Because of the skirt and all of the material in the LVOT. So it's not unusual to find your immediate post-procedure mean gradient of around 20 or so with the sapien and small annulus. So I know a lot of my colleagues have switched for those smaller annulus to back to Medtronic and self-expanding, because it's a much lower profile.
I have a question to Osman. Osman, if someone has a TAVI done and have a paravalvular leak, mostly due to calcium spicules or something, so at what time would you like to close it with a device? Paravalvular leak.
Gee, so it's if it's severe PVL.
No. Maybe moderate. You are done with the TAVI, patient discharge. in follow-up?
So not at that point. So definitely
yeah.
not at that time unless it's severe. And despite ballooning and everything, you can't get rid of severe. If it's moderate, I would leave it. As you know, these valves tend to gradually expand over time, and I would reassess it in 4 to 6 weeks and see what it looks like. A lot of times, once the protamine goes in and there's some endothelialization around the valve, these leaks tend to become better. So I would reassess in a month and a half, and then decide if anything further needs to be done.
There's a question about what about cerebral protection device? So, right now jury is out there. And I think in Pakistan with the cost issues, until there's definitive indication of the guidelines showing robust data for benefit, theoretically it made sense, but the data has not been there. So thoughts from the panelists?
So
I agree.
Yeah, the recent trial was negative that was presented from US. There's a PROTECT trial coming from the British, which will be probably in summers this year. I presume that will put a nail in this coffin for the end. Yes, but I have seen its benefit in some patients. The MRI data does suggest that it might be beneficial, but then again, there is no even selection criteria being devised from these trials. So at the moment, probably not. In Pakistan, no. Outside Pakistan, probably in some cases.
If you look at the MRI data, even to the valve crossing, after the valve crossing, when they did MRIs, there was about 15% people had small emboli in their brain. So it just goes to how careful you should be with the manipulation of the equipment in the aorta. But theoretically,
they have the same data with transcranial Dopplers during diagnostic angiography and PCI also. Once you go over the arch, all of that, the transcranial Dopplers go very loud. So, there's just no clear patient selection criteria, although it would be nice to have if there's severe aortic arch plaque or ulcerated plaque and grade 4 plaque, then if it's there, then I would probably use it if it was available.
Osman, but the flip side of the coin is you will be manipulating your device across that same calcified arch as well. So you might end up doing something.
More harm, exactly.
So yeah, you have to be careful with both sides.
You're not seeing extra manipulation before you.
Osman means more calcium on the left side, and then he comes.
Just put it in this from the neck right here.
All right, I think it was an excellent session, and everything was covered very nicely. And so these talks should be available online as well soon, hopefully by next week. I know Asaad has been after me to get them online. And so thank you, Osman. Thank you to all the panelists. Great session. I loved it. I learned a lot from it. And hopefully all the participants did so. And surprisingly, despite Ramzan, we had about 120 people log in online, and physically also in centers, people were listening to the talk. So great show as well. A lot of people showed up for the talk. So, all right. Thank you again, everyone, for joining. Happy Ramzan, and take care.